Welcome to the Department of Orthopaedics and Sports Medicine June Grand Rounds. One announcement: we're gonna hold off on our kudos until next month because the list of recipient residents includes only people who are away on vacation. So we'll save that until they're back. The other announcement is everybody is aware that we've had a recruitment process in place to find a replacement for Christine Palasigi. And we are now down to one candidate. We haven't quite worked out the contract with her yet, but I'm about 100% certain she will be within place and probably by the end of the week. Is that right, Dr. Kwan? Chris? Yes. Yes. She'll probably be hired by the end of the week, and so we're really excited. She's, I don't want to say her name quite yet until she signs her offer letter, but she's going to be fantastic. Thanks to Dr. Kwan and Dr. Tatesman and Teresa Jones, who helped organize this mini search for us. So this morning, we're going to talk about hip impingement. What is the current state of the art? Where are we in 2019? I know I find this topic to be a little bit confusing. It seems to be very cyclical with opinions changing relatively rapidly. So I am looking forward to Dr. Tipton, who's one of our PGY4s, and Dr. Hagen, who is the surgical director at our sports medicine clinic and specializes in hip arthroscopy to help clarify this for me. So welcome, Cody.
Good morning. I'm Cody Tipton. I'm one of the PGY4 residents. This morning I'm honored to begin our discussion and review of the diagnosis and the management of hip impingement. I'll be followed by our own expert in the field of hip preservation, Dr. Hagen, who's going to discuss with us in more detail the controversy surrounding FAI, a presentation of some cases, and the surgical outcomes. We have nothing to disclose. Briefly as an outline, we'll begin by discussing the anatomy and pathophysiology that's pertinent, the epidemiology, risk factors, and natural history of FAI, its clinical features, appropriate workup for the patient that comes to us in our clinic, and briefly how we treat them before we get into a more candid discussion with the current state of where we are. But first, a clip from the 2017 NBA Conference Finals. Some of you watched this game where the Celtics were trailing by as much as 21 points, but were led by Isaiah Thomas to a 20-10 run in the third quarter, coming back and winning this game 3, snapping the Cleveland Cavaliers' 13 playoff game win streak.
The injury happened back in March. I went in for a layup in the third quarter, and Karl Anthony Towns had fell on me. It jerked my leg a little awkward position. So from March to May, I played through it, and obviously I made it worse. In the playoffs, my hips started feeling a little different, like a little discomfort, and I played till I literally couldn't run anymore. I just wish I was able to be healthy and be able to give more, because I felt like we could have won that series.
So what exactly is this pathology that ended Isaiah Thomas's game season, as well as the Celtics season, could be blamed for this? It's defined as this osseous abnormality of the proximal femur and acetabulum that through the process of hip motion result in hip pain and eventual damage to the acetabular rim complex. While the cause of the deformity remains a bit of a mystery, the pathophysiology of hip impingement is a little bit better understood. The basic principles is that through a process of hip motion, abnormal forces cause progressive labral and cartilage injury. First, we'll talk about the CAM mechanism, which is a proximal femoral deformity that affects the anterior superior acetabular rim. It causes an inside-out chondral injury, starting at the chondrolabral junction. And then there's the pincer mechanism, which is due to acetabular overcoverage. In addition to the anterior superior impingement that occurs, there's a posterior inferior directed subluxating force at the capsular margin. The crushing mechanism against the femoral neck leads to an overloading injury of the posterior inferior acetabular cartilage and posterior medial femoral head in addition to the anterior superior. These deformities, however, do not occur in isolation. and can be a mixed picture. And a large prospective study by Closey found that the CAM deformity is actually the most prevalent morphology, followed closely by the mixed picture, with isolated pincer deformities being quite rare. Briefly about labral anatomy. It's a fibrocartilage rim that deepens the socket, increases the articular surface and volume, and emerges with the cartilage in the acetabulum through a 1 to 2 millimeter transitional zone. It provides a suction seal that we'll demonstrate arthroscopically here. When the labrum is torn, the suction seal is lost, which is necessary for hip stability, cartilage, and cartilage health. So why does it matter? The natural history of hip impingement has been well studied in the last 2 decades extensively, but we still have not really come to a conclusion about whether or not there's a relationship with the long-term morbidity. The literature we currently have would lean towards the abnormal morphology of FAI is a causative factor, both as a pain generator, but also in the development of a degenerative joint disease. But again, this literature is controversial. The rate of diagnosis and treatment of FAI has increased almost 400% over the last 10 years. So in 2016, 22 panel members from 9 countries convened, and they established this Warwick Agreement on femoral acetabular impingement. This is now endorsed by 25 clinical societies, and it's the consensus on the diagnosis and the management. To reach a diagnosis, we should have the appropriate symptoms, the positive clinical signs, and the appropriate image findings, just like most things we diagnose. They also agreed upon a suitable treatment, which does include conservative care, rehab, and arthroscopic versus open surgery. So there's many unknowns when it comes to impingement, specifically who gets it and why. Although the FAI population is pretty diverse, most of the patients are young and active, participate in rec or occupational activities that require repetitive hip flexion. And a few studies have demonstrated that it's more common in men, and the prevalence in football has also been studied. The other commonly affected athletes are hurdlers, female dancers, and while we don't know why some people have very small osseous deformities, they still develop symptoms caused by this repetitive trauma. Goodman and his team described a post-slip morphology theory that's associated with hip arthritis. They theorized that possibly the CAM lesion or deficient offset is a result of a silent or subclinical skiffy. He also proposed a genetic predisposition, finding that siblings were 2.8 times as likely to have a CAM, 2 times as likely to have a pincer, and that the contralateral hip radiographically also showed these lesions, though they were rarely symptomatic. So how do these patients show up in our clinic? The vast majority of them will have groin pain, but usually it's pretty nonspecific. They may describe that their pain is exacerbated by flexion activities, and so it's important to not just have them tell you where and how the pain is, but specifically within the motions and activities that they're performing. The differential diagnosis of a person that comes in with hip pain is extensive, and so we have to be pretty thorough in our understanding of the anatomy. It's our clinical suspicion through our exam and their history to be able to decipher between all these diagnoses and counsel our patients appropriately, knowing when we should be referring them for surgical consultation. So how do they examine? There's not really a pathognomonic physical exam for FAI. Its diagnostic accuracy has been well studied of the exams that we do use, and although fairly sensitive, they're not very specific. Weiss and his team showed a strong association between the internal rotation of patients that are held in 90 degrees of flexion, and he found that the control group that are asymptomatic have, on average, 28 degrees of internal rotation, only 4 in those that are hurting. So the imaging that we get throughout this workup should include a weight-bearing AP pelvis, a lateral hip x-ray. The 45-degree Dunn lateral has been shown to show the maximum deformity, which is helpful when we come to our measurements. And then an MRI of the hip, not necessarily an MRI of the pelvis. There are several radiographic findings that we should review quickly for CAM and pincer lesions. Our AP is the best to evaluate our pincer lesions for detection of retroversion and global versus focal overcoverage on the AP. The lateral center edge angle is used to measure this over or under coverage, and to determine it, we draw a line through the femoral head that's perpendicular to the transverse axis of the pelvis. The second line is then drawn through the center of the femoral head passing through the most superlateral portion of the acetabulum, and the angle created by this intersection is the lateral center edge angle. Those with undercoverage are said to have dysplasia if they have less than 20 degrees on this alpha angle, and those with greater than 40 are the patients that we're here discussing today with a pincer lesion of greater than 40 degrees. And we would say that somewhere between 25 and 40 are what we call normal. The next radiographic sign is our crossover sign. It's present when the anterior wall projects lateral to the posterior wall before converging at the sourceal. The posterior wall sign indicates the posterior wall is deficient, and it's present when the center of the femoral head is located lateral to the posterior wall. A truly retroverted pelvis will have both of these signs, but is also seen in dysplasia. A prominent ischial spine sign is when the portion of the ischial spine is within the pelvic rim, another radiographic sign that's suggestive of our retroversion. And then both on our AP and our lateral, we should be able to identify the non-spherical femoral head. Onto our lateral imaging, as previously mentioned, we should be using our lateral done to demonstrate the maximum amount of deformity that's present, and that we should be performing what's most commonly performed, although controversial, is our alpha angle. The first arm of the angle is drawn from the center of the femoral neck after making a best fit circle. And the second arm is drawn from the center of the femoral head to the point where the femoral head neck junction extends just beyond the margin of the best fit circle, also known as our alpha point. There is some debate that remains regarding the normal and abnormal alpha recommendations. It's ranging in the literature from 42 to 63 degrees, but the majority of authors believe that anything above 50 to 55 is abnormal. With that said, abnormal cam lesions have been seen in up to 25% of asymptomatic hips. The other measure or quantitative radiographic parameter we use in FAI is the head neck offset ratio. This is measured by first determining the axis of the femoral neck, drawing parallel lines both at the anterolateral femoral head, but also at the anterolateral femoral neck. The distance between these two is defined as the head neck offset, and the ratio is calculated by taking this number over the diameter of the femoral head. A number less than 8 or 0.17 on ratio we define as abnormal. Lastly, many patients will present to us with MRIs, but also we'll get them in with our surgical planning. And the MRA is actually the most reliable study to detect our labral injuries. The sensitivity of the arthrogram ranges between 76 and 91%, as compared to only 30% for the non-contrast 1.5 Tesla MR. The 3 Tesla MR has been studied without contrast and has shown pretty similar sensitivities compared to the MRA. So it is a suitable a substitute depending on its availability. MRA is important, however, to rule out our AV and stress fractures when our patients are presenting with hip pain. Lastly, when our diagnosis remains in question, a diagnostic image-guided articular hip injection can be used to help to rule out whether or not our hip pain is truly intra-articular. So why does it all matter? Con and his team looked at the alpha angles of 340 hips beginning at a 4-year period and found that of the small percentage of hips that became painful, 50% of them had cam deformities, while only 12% of the remaining asymptomatic hips had a cam. However, they did find that with an alpha angle of greater than 60, there's a significant increase in the relative risk of developing symptoms. And while there seems to be plenty of conflicting data back and forth between the literature on whether or not this was not the only group that found these findings. The Czech study investigated development of symptomatic osteoarthritis looking at alpha angles and found an odd ratio of 3.6 with an alpha angle of greater than 60 and 9.6 with an alpha angle of greater than 83. Thomas's group found a 5% increase in radiographic osteoarthritis with an increased risk going on to total hip arthroplasty and a 4% increase with every 1 degree greater than 65. The literature surrounding pincer lesions is a little less convincing, and some of the same authors that found positive findings with the cam lesions were unable to demonstrate a relationship between osteoarthritis and the pincer lesion. So before we dive into our surgical indications and outcomes, it's important to first attempt conservative measures. There is no data available on the effectiveness of non-operative treatment for impingement. So for patients that are involved in activities that are aggravating our hip or that aggravate their hip pain, generally we're recommending that they discontinue those activities. But many of the patients that present to us, such as our young athletic population, are unwilling to do so. It has been proposed out of HSS, who have coined this layered concept to the hip, and they've found that proceeding with conservative management first is great at addressing the third and fourth layer that they describe here, which are mostly extra-articular pathologies, even in the setting of radiographic impingement. So when all else fails and they turn to us for surgery, we have our goals of obtaining functional range of motion, repairing the damaged labrum, even though there's no firm evidence yet, as we'll discuss more, on whether or not the osteoarthritis is prevented by obtaining this impingement-free motion. So once we've elected to operate, how we treat is pretty surgeon-dependent on experience with and without hip arthroscopy and what pathology is present. Historically, surgical dislocation was the mainstay of our treatment. But as we become more facile with our technique and arthroscopy, it's strongly favored as a minimally invasive approach. Correcting the abnormal osseous anatomy is vital for addressing the patient's pain and preventing reoperation. So for now, there's currently no indication to prophylactically do surgery on the asymptomatic patients. So with that said, I'll step out of the way and let Dr. Hagen take us through a few cases.
Good morning, everybody. Can everyone hear me okay? Thank you, Dr. Tipton, for that excellent overview on FAI syndrome. And I'll pick up where Cody left off and start with some cases, as well as what hip preservationists have come to as consensus regarding this diagnosis, and then where the controversy lies. There's a lot of controversy, so I'm going to focus on a few points that I think are important there. So getting into these cases, the first is our standard CAM lesion. This is a 22-year-old gentleman who presented with 10 years of bilateral hip pain, the left side greater than the right. Can't recall any injury specifically. He's a golfer, and it's really that left leading leg that bothers him during his swing. He was previously very active with sports, but now is pretty limited due to the pain. When he came to the clinic, he described that classic C-sign distribution, and that really bothered him when he was squatting or pivoting. He's tried anti-inflammatories as well as 3 separate courses of formal PT over the last 10 years. And each time he did these, he felt a lot better, and that's sort of what's kept him at bay for the last 10 years before he presented. He's otherwise healthy. On his exam, you can see that he has decreased range of motion with flexion of the hip, particularly on that left side compared to the right, and he does have positive impingement signs bilaterally. Here on the weight-bearing AP radiograph, you can see that in terms of the left hip, there's no acetabular retroversion, and he's got normal coverage on the pincer side. On his lateral views of both hips, you can see bilateral cam deformities, and on that left side particularly, that alpha angle, which Dr. Tipton described, is measuring 70 degrees. You can see that reduced head-neck offset there. So in light of these radiographs and his symptoms, we did end up getting an MRI. And my personal preference is to do the 3 Tesla MRI rather than the MR arthrogram. I find that the arthrogram is pretty painful for patients to undergo, and so this is just a bit more comfortable for them, and as Dr. Tipton described, has pretty much equivalent sensitivity for detection of labral tears. You can see on these radial and coronal images the area where the labral tear is. So how did we do with this patient in terms of this Warwick agreement? I would say in terms of his symptoms, he definitely has impingement-related pain with squatting activity type motions. His exam is consistent with FAI syndrome in that he has reduction of internal rotation and flexion, and imaging findings are also consistent with our criteria. So in someone like this, who has kind of what quote-unquote, I think, slam dunk diagnosis for this condition, I don't necessarily make them go through the rigors of an ultrasound-guided injection, as I feel that They, have kind of already been through a lot of treatment so far, and in my opinion, the diagnosis is pretty clear. So we did proceed with surgery on this gentleman. Intraoperatively, on the top left picture, you can see the area where he's got focal cartilage delamination at the area of the labral tear. That's the probe kind of between those two layers there. In addition, even though he's only 22, you can see that he's got multifocal cartilage wear throughout the acetabulum, as well as even on the femoral head at that time. So I peeled back the labrum slightly in order to debride down the bone on the acetabular surface to make room for anchors, which we then placed to repair. Once reducing this hip, I brought his hip into flexion. You can see there's a focal area where the head-neck junction is hitting the labrum and causing liftoff of the labrum in that area, which is a little bit easier to see dynamically than on a static image. But thus, the area of that reduced offset is corrected. So radiographically, you can see these changes. Reduction of the alpha angle to less than 45 degrees, while not really changing anything about the center edge angle. At 6 months, his most recent follow-up, so far he's very happy with that left hip, and he's actually returned to sporting activity, and the right hip has started to bother him more. His range of motion on the left side is actually increased from his pre-op exam, which I don't always see, quite honestly, but the right hip is starting to get a bit stiffer, as well as having those impingement signs, and so he's planning on having his right hips done this fall. I do patient-reported outcome measures on all my hip arthroscopy patients, and so this is the HOOS score, which has been well-validated for arthroscopic surgery for FAI syndrome. And you can see that in the domains of symptoms and quality of life, he's met the minimal clinically important difference. And that's at 6 months. So we'll move on to the second case. This is a pincer type. This will be quite different from the last one. This is a much younger patient as well. This girl's 13 years old, and she's had left hip pain for 2 years. This first started when she did gymnastics, and so the natural treatment for that was to have her stop gymnastics, which did help her pain a lot. And then she was able to return to other sports, of which she really enjoys softball the most. But then the pain returned again when she started doing track and field. She's a very active girl. At the point where she came to see me, she was unable to play any sports now due to her hip pain. And she's described this as anterior pain brought out by running, as also as going upstairs. She's also tried a course of physical therapy as well as anti-inflammatories. On her exam, you can see that she has reduced hip flexion, but her motion is actually similar internally and externally rotating. Also with direct flexion, that brought about pain, in addition to the pain from the impingement maneuvers. She has internal snapping due to the psoas tendon in addition to this. She has no soft tissue inflammation, and here are her weight-bearing x-rays. On these x-rays, you can see that she's got actual normal lateral coverage of her acetabulum, but she does have this positive crossover sign, which Dr. Tipton described. Additionally, you can see the ischial spine. This is a slightly rotated AP image, but I think it's still close enough that we can see these measurements. On the false profile view, you can see there's slight prominence of her AIIS as well, the anterior inferior iliac spine. She has no cam lesion with an alpha angle less than 50 degrees on her lateral x-rays. She came in with an arthrogram already, and you can see in that area of the anterior labrum where the separation is from the acetabulum. So Warwick agreement on this lady, I would say that she also has position and motion-related pain in the hip, and her impingement signs are positive, as well as meeting radiographic criteria for a pincer lesion. However, she's only 13, and in adolescence, I have a very, usually for everybody that comes into clinic, I make them kind of jump through a few hoops before we think about surgery. And there's good data on this. This was a study that came out of Rady Children's Hospital where they looked at patients under the age of 21 presenting with hip pain. And they followed these patients for 2 years with 71% follow-up. Everybody that walked through the door, no matter what treatment they had had to date, underwent the same 6 weeks of formal hip-directed physical therapy with activity modification. And they found out that cohort that 70% of these patients got better just with that alone. Of those that didn't get better, they then did an intra-articular cortisone injection and found again 12% of this population, again, resolved their pain and was able to return to activity. So that left them with only 17 out of the initial 93 that required surgery for their hip pain. So with this girl, we did do a cortisone injection and some continued physical therapy as well as activity modification, which initially worked well for her, but then she returned due to complaints of return of her pain. So we were discussing surgery, and so in this girl, I did elect to get a preoperative CT scan given the retroversion that I saw on the AP radiographs, mostly looking to make sure that there wasn't a global retroversion issue. And you can see that as we go cranially through caudally, that the version is quite normal, actually. So I think this is important, especially in these cases of retroversion, because the x-rays can really be inaccurate sometimes in detecting the amount of version of the acetabulum. You really need axial imaging. From the CT, we also got a 3D reformat, and you can see the focal area of impingement, is not necessarily due to the version of her acetabulum, but due to that kind of low-lying AIIS that she has. So this gets into the topic of subspine impingement, which is a form of extra-articular hip impingement. And this has only been recently described, primarily coming out of the work out of HSS again. And there's 3 different types that have been defined, with types 2 and 3 being more pathologic. They found that in patients with these type 2 and 3 AISs that there was restriction of range of motion in flexion. So looking at our girl's CT scan, you can see that there is a low-lying AIS extending towards the level of the rim. Intraoperatively, here are her images. So on the top left and middle, you can see that she's got a very focal tear of the labrum with a lot of bruising around the labrum in that area. We peel back the labrum, and the soft tissue is somewhat obscuring it, but that's kind of the level of where the AIS is coming down. And so pulling back that soft tissue and debriding that bone was important to reduce that area of impingement. Small labral repair. And then when I brought her hip through range of motion, I did not find any areas of impingement based from the femoral head neck junction, so we did not do a CAM osteoplasty. Here are her postoperative x-rays. So not much in terms of changing the overall coverage of the acetabulum laterally, but you can see the reduction of the crossover angle as well as that area of the AIS that's been removed. Here's another view of that. 6 months, how's she doing? She's doing great. She's returned to softball, feels 100%, isn't complaining about a hip at all. Here are her preoperative to 6-month WHOOS scores, where she's met MCID in all subdomains. Last of the cases here that I'll show, this is a 26-year-old girl with more of the mixed type that we discussed. 12 years of pain, C-sign distribution, worse with certain impingement activities, pretty active, has stopped to run due to the pain. She also has done 6 weeks of formal physical therapy by the time she's arrived in clinic, as well as is on regular anti-inflammatories. Again, she has pain with direct flexion as well as reduction in internal rotation, positive impingement signs, no soft tissue tenderness. X-rays here show slight overcoverage laterally of the acetabulum, no crossover sign though, and then a small cam lesion. 3D CT again was obtained, and you can see that focal area of impingement, that region. Oops. Here's the MRI that we obtained, and through these coronal slices, you can see she has got a large paralabral cyst in association with her labral tear. So again, she meets criteria in terms of symptoms, exam, and imaging. And again, I felt like this was a pretty clear diagnosis in this case, and she was someone who had already done a fair amount of conservative management. We discussed cortisone injection, which she declined in favor of surgery. And here intraoperatively, you can see the area of the labral tear, as well as in this region here is where the cyst was located, and then the pincer lesion, which was removed, labral repaired. Here's the femoral head neck area, which we removed the bone, And then this is, dynamically bringing her hip up into flexion. You can see a gap between the labrum and the femoral head neck junction. Postoperative radiographs show correction of the center edge angle. And then on our lateral view, you can see the correction of the cam deformity. Alpha angle now is reduced to less than 45 degrees. In 6 months, she's doing great, has met MCID again for all of her outcome measures. She's returned to running, which she was thrilled about. So, of course, this is grand rounds. I'm going to show my happy, successful patients, but I thought it was important to dive into some of the general literature on this topic as well to see how other patients have fared. Rather than show individual, case series from different surgeons, I selected this meta-analysis, which I think was really well done. And this was a total cohort of about 2,000 hips across 31 studies, mostly level 3 and 4 evidence, so retrospective and case reviews, case studies. But all patient-reported outcomes improved significantly at the 2-year mark. So you can see like modified Harris, hip, the Haas, Womack, et cetera, with the VAS declining. There is a 90% return to sport, and reoperation risk was low. Risk of complications was also low, and most patients did not require bilateral FAI surgery. In terms of better evidence, though, there is one RCT that I wanted to discuss that, again, I think was very well done. This was the UK fashion trial, which was recently published in The Lancet. This was 350 patients that they randomized to surgery versus a non-operative group, and that non-operative group had a very well-defined structured program that they followed. They only had 8% crossover into surgery, which I think, again, was excellent. There is one other RCT that had been published right before this in AJSM with a really high crossover rate of about 40%, I would say, making it really hard to distinguish the difference between those two groups. But here with 8% crossover, they found that both groups improved in terms of their IHOT scores, which is another patient-reported outcome measure. However, the improvement in the surgery group was greater than that of the non-operative group, and that met the minimal clinically important difference in terms of their difference in improvement. But what about the dollars? So this is a recent cost-effective analysis on hip arthroscopy for FAI syndrome. And this is, published by the who's who in hip preservation, I would say. And they did find that in 99% of trials in this study, hip arthroscopy was the preferred cost-effective strategy with a 10-year societal savings of $70,000 over non-operative treatment. So what I would say the consensus from a hip preservation standpoint is that FAI syndrome has been well defined, and there are validated outcome measures to study this. And patients seem to do well after FAI surgery when you select the patient with the correct diagnosis to undergo this. So I thought it'd be also important to talk about patients that don't do so well. So here is one representative case of that. This is a lady that I operated on earlier in my practice. This is a 50-year-old woman who's had left hip pain for 3 years, atraumatic in nature. Pain, again, is anterior, radiates down the thigh, is worse with flexion activities, but also bothers her kind of all the time, including at night when she's at rest. She's tried anti-inflammatories. She's also had a bursal injection at one point without significant relief. Otherwise, pretty healthy. She does take an occasional Vicodin, though. On her exam, you can see that she has normal gain posture, but most impressive to me was that her lack of good core strength. With single leg testing, she really had a lot of difficulty accomplishing that. Passive range of motion was slightly less on the left side and had pain. And she really had just a painful hip all over. The soft tissue was very tender, a lot of pain with muscle resistance testing, as well as pain on the peritrochanteric region. Here are her radiographs. Again, showing some lateral overcoverage but maintenance of the joint space. Lateral x-ray, again, shows a small cam lesion here. And she came in already with an MR arthrogram demonstrating a labral tear as well as an associated labral cyst. I did find this area of focal chondral loss on the MRI, which concerned me and which I discussed with her. So Warwick and Grima on this patient, I would say she didn't necessarily only have position-related pain. Additionally, the exam was a little bit confusing. She does have some radiographic criteria meeting FAI syndrome. So we went with a non-operative treatment course. She did 6 weeks of physical therapy, and it was actually impressive how much she improved on this. Her right hip symptoms had completely resolved, and the left hip, a lot of that soft tissue inflammation had improved, leaving only kind of this mechanical pain in impingement positions. I offered her a cortisone injection with continued conservative management, which she declined, complaining that pain was interfering with her active lifestyle. And so we ended up operating on her hip. And then here you can see kind of this very broad area of cartilage loss, which I think was really much more impressive than the MRI showed, with exposed bone that's bipolar on just both the femoral head as well as the acetabulum. So we repaired the labrum and removed the cam. And again, this is one of my earlier cases. I'm not as proud about the cam osteoplasty, but we did manage to reduce her alpha angle to under 50 degrees, and her center edge angle had been improved. And she did okay for about 3 months, and then she came back with hip pain, as you might anticipate. 8 months post-op, these are her repeat x-rays. You can see there's been slight focal narrowing of a millimeter on that weight-bearing joint surface. We went back to conservative management, did a cortisone injection with excellent temporary relief. She's taking anti-inflammatories, also still on Tylenol with codeine now, and complaining of a lot of pain with flexion activities. And she was very adamant that she didn't want a hip replacement. Here's a non-contrast MRI, and it's significant for a few findings. You can see that there's worsening chondral damage. I mean, she essentially has arthritis, in my opinion, missed area of impingement, and a loose body. After a lot of back and forth with this patient, she, wanted to proceed with another hip arthroscopy, which, probably against my better judgment, learned a lot from this case. But you can see, I think it is informative, and I wanted to demonstrate just kind of the amount of joint destruction that happened in a year for her. So there's now really widespread loss of cartilage on the acetabulum, as well as on the femoral head. But her labral tear had healed. So at most recent follow-up, she's still taking a Vicodin. Her pain is unchanged, as I had expected and, counseled her on about before surgery. And she's awaiting total hip arthroplasty. All right, so who do we know doesn't do well with hip arthroscopy? And I think this is really important. If you remember one thing from this talk, please remember this. But people with arthritis should not probably have hip arthroscopy. This is, a lot of literature showing that patients with a tonus score greater than 2 or greater convert to total hip within 2 years. If you have reduction of the joint space on weight-bearing radiographs, again, greater 80% conversion to total hip within 5 years. In addition, along those lines, patients that are older, you really have to exercise caution, as even if they have a perfect-looking joint, they still are at high risk of converting to total hip after arthroscopy. Additionally, we won't touch on this too much, but patients with hip dysplasia don't do well with hip arthroscopy either. The main problem with there being a bony undercoverage problem, not overcoverage, and you can't add bone back arthroscopically. Other factors have been shown to also be associated with poorer outcomes. I'm going to give a shout out to one of our interns, Jay, who helped me with this study using the source group and the market stand database. And this is probably the largest database study on hip arthroscopy to date. And we looked at patients between 2007 and 2014 who underwent hip arthroscopy and found a 10% conversion to total hip, which really was age stratified. So you can see in the older age group, really wrong button, sorry. Their survival much lower. Other risk factors that we found in our multivariable analysis was, ICD-9-10 codes of osteoarthritis, and then obesity, depression, and recent opioid use. So the consensus, again, is I think in patients with arthritis, these patients should not be receiving a hip preservation surgery, and should really critically consider operating on older patients in light of the high risk of conversion to total hip after arthroscopy. So where does the controversy lie? And as I mentioned, there's a lot that we could talk about here. I'm just going to focus on 3 points that I thought were interesting. So Cody has demonstrated some evidence showing that we believe FAI syndrome leads to early arthritis, but is there any evidence to show that hip arthroscopy can help delay this progression? Also, what do we do about patients that don't meet these radiographic criteria for FAI but also have labral tears? There's a tear, do we need to fix it? And then why don't certain insurers in Washington State cover surgery for FAI? So focusing on the first question, the short answer is we don't know. There are no well-done longitudinal studies to prove that we're changing their natural history. This is indirect evidence from a 2-year study showing that patients who received osteoplasty and labral repair for FAI syndrome did have reduction in their T1 row as well as acetabular bone mineral density, suggesting that that area of impingement had lessened the pressure on the cartilage after surgery. But then there's also, a study showing that they actually did worse at the 1 year. So this is a cohort study looking at 2 groups, a non-operative and an operative group. The operative group underwent osteoplasty with labral repair, and you can see their degenerative scores at 1 year were worse than in the non-operative group. So the jury's still out there, and this the bottom study is still underway, and they're collecting data longer term. In terms of long-term outcomes, again, there's no great studies out there. This is a level 3 study, but probably has the best follow-up. And this comes from the Philippon group, where 79 patients with 94% follow-up at 10 years. I don't know how he had such great follow-up, but in any case, he shows that these patients are still having clinically significant improvement with a 15% conversion to total hip over a 10-year period. Much higher if you operate on someone with more arthritis, though, as you can imagine. The picture on the right is a case from his cohort that was published in JBJS showing a professional hockey player who underwent surgery on the right hip but not the left hip. And then at 10-year follow-up, you can see there's a reduction of weight-bearing surface on the left compared to the right side. So a lot of indirect evidence that is not super strong, and I think we'll have to wait and see more on that topic. All right, what about these patients that have labral tears but no FAI? What do we do about them? And I see this all the time. People come into my office and they bring their MRI and they say, I have a torn labrum, you have to fix it. So it's true that labral tears can cause pain. I think there are a lot of pain fibers that are in that area of the labrum, particularly concentrated in that anterior superior region where tears occur. But it's also true that there are pain fibers throughout the hip, like in every tissue that's in the hip joint. And so it's really hard to say that the pain is definitely coming from the labral tear. Furthermore, labral tears are extremely common. So this is a study looking at older patients over the age of 50, and in patients that had arthritis with a joint space width less than 2 millimeters, there was a 100% incidence of labral tears on the MRI. Even in patients that had maintained joint space, that incidence was greater than 90%. Okay, so I think it's a normal part of the aging process of the hip. And also, people that don't have pain have labral tears. So this is a study looking at 100 patients under the age of 60 now who had a symptomatic hip due to FAI syndrome, had evidence of a labral tear. Their other contralateral non-symptomatic hip was also imaged, and about half of those also had labral tears, despite not having symptoms. Furthermore, there's a lot of stuff that causes pain in the hip, as Dr. Tipton elucidated too. And that layered concept is really important because the muscle and the nerve fibers, I think, are a main contributor to pain for these patients. And so really trying to tease out what could be the cause of their pain and not just necessarily attributing it to the labral tear is really important. On top of that layered approach, I would also add a psychosomatic layer. There's studies showing that the hip arthroscopy population has a higher incidence of mental illness for whatever reason that might be, as well as that their mental health scores are really closely related to their patient-reported outcome measures. So I would say that labral tears and pain probably are not one and the same, but there is an intersection. Similarly with FAI, this is kind of how I internalize this in my brain in terms of that these are kind of all separate things and there is some overlap. And then my philosophy on this really is, and this is just my opinion, but labral tear itself I don't think is really a diagnosis, and you really have to come up with what is the underlying cause, of which the most common is probably degeneration and aging, right? But that is really critical to understand why they're getting this tear, if it's symptomatic, to decide how you want to go about treating it using the best available evidence. So that brings me to the last point, is why won't certain insurers in Washington State cover this? And this came from the HTCC document where, based on available literature in 2011, they felt that there was insufficient evidence to support the use of widespread use of arthroscopy for FAI syndrome. And, Dr. Manner is in the audience and can probably speak more on this as well. But, essentially there were 6 criteria that they investigated, and I'm not going to go into each of these bullet points, but I would have to agree in 2011, I think that was the state of the evidence. I don't think there was strong stuff to support any of these questions. I think now, though, particularly in the last 2 years, there's been a lot more to address a lot of these questions, and so I'm really excited for the upcoming review to see, what comes uncovered and what the consensus now will be. In addition to that, it still may be denied, and so there are also other ongoing RCTs that we'll have to wait and see what these results are. But that fashion trial that I showed earlier does have 2, 3, 5, and 10-year arms, as well as an Australia part of it where they are looking specifically at the degenerate scores to see what the impact is on the cartilage on MRI. There's also a Scandinavian trial where they're going to do osteoplasty with labral repair versus sham surgery and follow that for up to 10 years. And finally, this Canada trial should be close to getting published soon, as it's been going on for a while, but they're looking at osteoplasty and labral repair versus lavage plus or minus labral repair. So really getting at how much does that bony correction do for patients. So in summary, my take-home points on hip impingement here. This is a complex condition that has only recently been defined, and it's really a mix of clinical history, the exam, as well as imaging findings. I think patients do significantly improve after surgery for FAI syndrome, but we have no evidence that we're changing their natural history at all. And that's really a key thing that I tell patients when I see them is I can't say that I'm going to prevent them, and I probably will not be preventing them from getting arthritis, but the idea is to reduce their symptoms in the present state and allow them to get back to activities that they enjoy. And then the final point here is that I strongly believe that patients that have arthritis should not be undergoing surgery, as you can see from my personal failures on that. Thank you. Just bringing it back. One more thing in terms of if anyone was curious how Isaiah Thomas is doing, he did end up having surgery for this condition, and he returned to the Nuggets in February and played a few games and didn't do so great as compared to his pre-injury stats. But I included here a video from when his jersey got retired the other year. Let me come back up. You can turn the volume up.
Go back home and see my friends and family, and then also be able to go back to my college, the University of Washington, and be showered with love when I was.
If you want to watch the complete documentary, it's available on YouTube.
For the last month or so before I went back home, it was something I needed. One of the dopest moments of my life to be able to be honored, be able to have my jersey retired and put in the rafters at the University of Washington, something nobody can take from me. So that kind of re-energized me mentally and physically to go into the second half of the season with a positive mindset and to just finish strong.
Any questions?
Great talk, both of you guys. Thanks, Mia. My question that I've had on a number of these talks when I've been privileged to view them is, what happens with that cam deformity after you shave it away? Does it come back?
So,
and if
yeah.
it does, is that what's associated with perhaps failure over time? Or?
Good question. There have been longitudinal studies looking at that and have shown that the cam does not come back even in skeletally immature patients.
And that one question I had when you did the subspine impingement on that one skeletally immature patient, looked like you were into some of that apophysis there. Is that, and that doesn't?
That's not been, yeah, so the attachment of the direct height of the rectus is really quite broad, and there hasn't been shown to be any clinical significance on strength and flexion when you do the AIS decompression.
Thank you.
Thanks, you guys. That was great. So in kids' hips, we change them a lot and we do Salter osteotomies. And by nature of what you do, you swing the hip and anterior laterally cover it. Does anybody look to see if those patients are actually getting impingement? Because it's exactly where you're creating the deformity.
So that is a great question, and that is really how, with GONS, how FAI initially became defined really in the last 20 years was he was noticing that happening in patients who he did osteotomies on these periacetabular osteotomies, that they came back with continued hip pain. MRI showed presence of a labral tear. And so that's sort of how we got down this whole path initially.
So should we just sign them up to see you? As
No, I think it's a really tough question though, because undercoverage also is a problem that we know leads to degeneration due to the decrease in the contact area. And so I don't know what the right answer is, to be honest. Yeah.
have they showed that the difference between a Salter group versus a periacetabular in a kid such as a Dago or a Pemberton don't have the same issues?
That I don't know as specifically. That's a good question though. So we can look.
Resident project.
Yeah.
Thank you. That was great. When I was looking at some of those slides, even before you had mentioned it, for example, in your patient that did poorly, when I looked at that, I felt like, okay, that person actually does have early arthritis, even though the measurement of the cartilage thickness was okay. And even in the Philippon article, you had shown where the left side progressed, the right side didn't. If you look at the original films, the left side was already arthritic and perhaps the right side wasn't. So it seems like one of the keys is really defining who has arthritis and then what degree is acceptable and may respond to this. So how do you work patients up? It would seem there has to be something that you're doing besides eyeballing thickness of that superior cartilage.
Sure. Yeah, I actually did a study on that, and where I think the MRI can be very helpful because even though it's really hard to detect full thickness cartilage loss on an MRI, you can look for other signs that are very sensitive for that, mostly acetabular edema or cystic changes in the acetabulum. That has a really high correlation with presence of grade 4 lesions. The other important thing is, we found that people that have cartilage lesions on the femoral head are specifically poor players on this. And so, really paying attention on the MRI, I think, is kind of the best bet when the radiographs are, still meet that 2 millimeter criteria or TONUS criteria for outcomes. Yeah, good question, though. And I think the other tricky thing with this is, again, the whole thing is that we don't know that we're doing anything to change their natural history to begin with. And so just educating the patients on the limitations of the technology right now is really important. Yeah.
I was just going to ask, what do you think in terms of the causative mechanism for this, and do you think there's a role for either childhood or early adult, like deep flexion exercise? So one of my senior residents at Iowa had done a brief retrospective study looking at former Iowa wrestlers who'd probably spent about 25 years of their life, about 4 hours a day in deep flexion under heavy load. And so they're kind of an extreme of the sport. And basically every single former Iowa wrestler had cam lesions and had some degree of arthritis in their kind of middle age. And Dan Gable, who is like the most famous wrestler in the world probably, and was an Olympic athlete, he had spent coaching and wrestling probably, I don't know how many hours, 10,000 hours probably, 1 million hours wrestling. And he had bilateral hip replacements at a very young age, a relatively young age. So I just didn't know if there's a thought that those cam lesions, when they develop, do they develop in childhood? Because a lot of those wrestlers start wrestling when they're 4 or 5. So.
Do you want to take this one? Talked a little on the developmental nature.
I mean, we already touched base on kind of the discovery of what this is and how we figured out by us changing the acetabular morphology that we've found that this is an issue. But as far as the cam and the skiffy and how young these kids start wrestling, I would think that it's probably has some validity for the proposal, but I don't think we know who gets it and why. wrestlers get it, dancers get it, football players get it, and it's been studied extensively, but why they get it, is it because they do these activities? I think that there's a combination of being predisposed and then also the activities they choose to do.
Right, yeah, I mean, that's really, nobody has really answered that question. I don't really know the best way that you could design that trial, but there is thought that elevated contact pressure in that position really puts a developmental stress on the bone in people that are, growing and, leading to these lesions, yeah.
One thought would be, so with youth baseball, they look at
Yeah.
number of pitches. So, wrestlers have different seasons they participate in, for example, and so youth wrestling, you could probably track pretty well someone's number of matches and then
Sure.
how many did they participate in, like freestyle season and folk style season, and that's probably tracked pretty well. Parents record all the matches and all these things.
Yeah.
You'd probably retrospectively look back and say, like, this kid had this many matches for this many years and this many seasons, and see if there's an association. But
Yeah, I think similarly in football players, like linemen, that's another thing, yeah.
Okay, great talk, guys. So I had a question to kind of piggyback Dr. Chansey's question about how do you predict arthritis? Have you found, or do you find it helpful to get a degenerate type MRI to prognosticate? And then the kind of second part of the question is, if you see a focal cartilage lesion, do you do anything about it? Chondroplasty, microfracture, anything like that?
Sure. So I don't routinely get degenerate studies. I think with the 3T MRI and the radiographs, I can usually get, as well as patient age and other risk factors, I usually have a pretty good idea. And so I don't routinely use those, although I know some people in practice do. And then in terms of what to do with the cartilage, I thought about mentioning that in this under the controversy section, and I left it out. But right now, the thought is to do microfracture, and there's some studies, take-backs. They've shown that there's been growth of fiber cartilage in that area. But quite honestly, the outcomes on people who receive microfracture in their hip are really quite poor. When you follow, they're part of that cohort that fails, really. And so I'm not really a strong believer in that you're really doing anything by drilling those holes in the bone. Furthermore, the trajectory on that microfracture is extremely challenging. It's already, hard enough in the knee, but on the hip joint, you're really, relying on a 90-degree angle to try to get, and there's no drill right now that's on the market that can do that. And so you're relying on those awls, which aren't as good as drilling. Yeah.
Okay, thank you.
We do have one text-in question asking, do we routinely perform psychological screening on our patients considering surgery? Is there a set of exam findings predictive of poor findings? Physical exam.
Yes, so I do incorporate, kind of a global mental health score as part of the patient-reported outcome measures. I didn't include that on here. But then the second question is, there are a set of exam findings predictive of poor outcomes? I'm not as clear. There may be a few studies on that. I think in everything that I've read, though, the people that tend to do the worst are really the people that have the lower preoperative outcome measures, as you can imagine, as with like most of ortho, that's the same. But not really a specific exam finding that can correlate with that. Any other questions?